who's on first? So we're going to move into our second panel. And I would just like to introduce Emily Creelkamp, who is going to be our moderator. And Emily is a recent 2016, so not recent. Compared to me, recent. Very recent. But Emily is working at Children's of Wisconsin in Milwaukee. She's a graduate at Concordia University. She's in a casual position. She floats just about everywhere. And you've also just completed the sexual assault nurse examiner training. Very cool. And Emily's also on our WNA board of directors. She's the staff nurse representative. So Emily, I'm going to turn it over to you.
Good morning, everyone. I am pleased to be the moderator for this very timely and relevant topic for nurses, preparing nurses to respond to public health emergencies through a health disparities lens. WNA, in conjunction with the Wisconsin Center for Nursing, wanted to increase awareness for WNA members about this topic. The issue of nurses being prepared for public health emergencies goes beyond how to don PPE and infection control in the workplace. The WNA Board of Directors want to increase awareness of this topic from a nursing perspective and identify recommendations for WNA that will support nursing awareness and understanding of their possible role in responding to public health emergencies. The board will be utilizing recommendations number 8 from 2020 to 2030 Future of Nursing Report. I would like to start the forum with our first presenter, Karina Cochran, BSN RN. Karina works as a quality review specialist RN for Freighter in Menominee Falls and just graduated in December from the University of Wisconsin Oshkosh College of Nursing. She worked with Gina Denick Champion at WNA for her final capstone project. Welcome, Karina.
Thank you. Hi, everyone. See where I'm going to start here. I'll probably be saying the same things Emily just said. What nurses see, what nurses don't see, vulnerable populations. Karina Cochran just graduated in December, University of Wisconsin, Oshkosh. I had the honor of working with Gina Denick Champion as my mentor for my capstone project. My project was an extensive literature review on recommendation number 8, the Future of Nursing 2020-2030 report, charting a path to achieve health equity, put out by the National Academies of Sciences, Engineering, and Medicine. My project focus was recommendation number 8, like I said, nurses in disaster preparedness and public emergency response. A nurse's touch is far-reaching. The profession is proud to have nursing organizations across the globe that collaborate in closing educational gaps. According to the National Academies of Science, Engineering, and Medicine, 2021, nurses are often the first and only point of care in their communities. Recommendation number 8 states that to enable nurses to address inequities within communities, federal agencies, and other key stakeholders within and outside the nursing profession, we should strengthen and protect the nursing workforce during the response to such public health emergencies such as COVID, pandemic, the natural disasters that we have, and human disasters caused by violence. The reason for this project was to assist the Wisconsin Nurses Association with literature to support initiatives they will forego in the future. 15 minutes is not enough to talk time to talk about everything I found, but I will give you a high-level overview. My references are at the end of this presentation as a handout. The report mentions that for the United States to make substantial progress in achieving health equity, it will need to devote, resources and attention to the conditions that affect people's health and make expanded investments in building nurse capacity. Nursing schools will need to shift education, training, and mindsets to support nurses' new and expanded roles. Reading the entire report can be daunting. It's 503 pages long. Recommendation number 8 is 19 pages long. However, I found a podcast put out by the very same group who authored the report. I highly recommend the podcast, and the link is on this slide here. In this 8-part series podcast, they explore practical strategies for the nursing profession to advance health equity. You will hear stories and experiences of frontline nurses from a wide range of settings in the podcast. The podcast says that the United States has some of the poorest health outcomes. Health disparities run deep and leave people without equal opportunity to care. Nurses are in unique positions to address the root cause of poor health and reduce health disparities. The stories on the podcast helped me to learn keywords that I kept seeing throughout the literature. These keywords are confusing at first. I am no expert on them. I am still learning. Healthcare equity, ensuring that access to healthcare and high-quality care are available to all individuals and communities. Health disparities, health differences that adversely affect groups of people who have systemically experienced greater social or economical obstacles to health based on their racial group, religion, socioeconomic status, gender, mental health, cognitive, physical ability, sexual orientation, and geographic location. Health equity is the state in which everyone has the opportunities that groups have to achieve optimal health, leading to health equity is a state in which everyone has the opportunity to attain full health potential and no one is disadvantaged. Health inequities would be systemic differences in the opportunities that groups have to achieve optimal health, leading to unfair and avoidable differences. Social determinants of health. This is a long one. This is the one that gets confusing for some people. And it's talked about a lot in the media. Social determinants of health are conditions of the environment in which people live, learn, work, play, worship, and age, affecting a wide range of quality of life outcomes. These conditions include education, employment, health services, housing, income, physical environment, public safety, social environment, and transportation. Social determinants of health are sometimes called social influences. Vulnerable populations are groups that are unable to take care of themselves when a disaster occurs without help. Closing the gap. There are gaps in nursing's emergency preparedness because despite having met all the CMS emergency preparedness criteria, there are still gaps. The current public health emergency illuminated glaring gaps in the emergency preparedness and the harmful effects on nurses. Gaps in training are evident in nursing leadership. Results of the April 2020 ANA survey indicated gaps in crisis leadership, resulting in a lack of trust between hospital leadership and frontline nursing staff, including nurse specialists. Oh, and I'm sorry, I should go over those. Public, we want to, when we're addressing vulnerable populations, we want to increase the public's positive perception, the trust that they have in nurses. We want to develop data and use that data to find the most vulnerable populations. We want to collaborate with community services. We want to prepare vulnerable populations for disaster scenarios. We want to share ideas and teach each other by historical experiences by using nursing research. Individuals from vulnerable populations also need to be on the team because they will contribute valuable information about meeting their special needs for emergency planning and response decisions. We cannot achieve true health equity without nurses, which means we must do better for nurses. They must be supported in charting a path for themselves while they work to serve others. My literature review found that vulnerable population included nurses themselves. At all turns of my literature review, nurses were mentioned as being driven to care for others. Nurses all over the world continually educate themselves and heal patients using that education. The Nursing Ethics Provision 1 explains that the nurse practices with compassion and respect for inherent dignity, worth, and unique attributes of every person. According to the Wisconsin Nurses Association mission statement, they represent the interest of 90,000 nurses in Wisconsin and advocate for healthcare issues that affect nurses and the public. Sorry, I lost track of where I was. I read recommendation number 8 within the Future of Nursing 2020-2030 report during my clinical, but I was also fortunate to attend a class put on by the Wisconsin Central Nurses called Wisconsin Nurses Respond Now, preparing Wisconsin nurses to address the needs of vulnerable populations during a healthcare emergency. This class helped me to learn new terms as I tried to understand how a vulnerable population is affected during a disaster. The class explained that registered nurses must play a role in identifying vulnerable populations as the essential part of community preparedness. The online class used a storytelling narrative of how COVID-19 pandemic forced healthcare organizations to collect data, report data, and grasp the stark disparities experienced by vulnerable populations. According to the Nursing Scope and Standards of Practice 2015, nurses design and direct culturally congruent practice and services for the diverse consumers to improve access, promote positive outcomes, and reduce disparities. The COVID-19 pandemic revealed the exhaustion that is possible in nursing when an illness overloads the population. Minimizing harm to patients was a topic I considered when doing my research. As I began my research, I quickly realized that nurses are a vulnerable population because the surge of patient care falls upon the very people who dedicate caring for others before caring for themselves. While the Joint Commission that specifically measure facilities have the plans, procedures, and human resources needed to surge the workforce during a disaster, leaves them vulnerable to staffing shortages, increasing the likelihood that they will need to turn to a crisis standard of care. The Medscape Nurse Career Satisfaction Report of 2020 reported that high levels of nursing burnout in some cases quadrupled 6 months into the pandemic compared to pre-pandemic. Without self-care, we lose the ability to truly understand the vulnerability of others. During a crisis such as COVID-19, the nurses have witnessed racial tensions towards vulnerable populations, which causes further distress in the profession. I refer to the Provision 1 of the Nursing Code of Ethics again, and when nurses witness racial discrimination during times of crisis and uncertainty, it would be considered unethical to stay silent. The burden to speak up during patient care can cause further distress for a nurse. However, it is unethical according to the Code of Ethics to say nothing. Leadership must set principles to provide the nurse with a measured response that allows the unjust behavior to be addressed and also maintains the nurse's social status. Schauer and Dardis 2020 created a study to establish the prevalence of acute stress disorder and predictors of psychological stress among Jordanian nurses, because nurses are considered a vulnerable population. The implication for practice at the end of the study shared that findings warrant intensive efforts from healthcare institutions to provide psychosocial support services for nurses and nurse managers so they can collaborate at the forefront. People of color. An article by the U.S. Preventative Service Task Force stated that racism might increase adverse cognitive, psychological, and emotional effects. The cumulative chronic stress from racism or social injustice can accelerate physiologic mechanisms that lead to disease. Under conditions of scarcity, stress, and uncertainty, the delivery of medical care is more likely to be affected by racial bias, which furthers existing health inequities. Structural racism shapes who gets what, when, and how, from the disrespect of Black mothers during pregnancy and childbirth to the lack of clean water in Flint, Michigan, and Native American reservations. During COVID-19, this means that the color of one's skin, not the severity of symptoms, determines access to timely testing, hospitalization, treatment, PPE, community resources, and even how information is disseminated. The next vulnerable population that I found are elderly. More than 70% of those that died as a result of Hurricane Katrina were elderly. They during times of disaster, they need help with medication management, independent living situations. Sometimes the data will say that the elderly, they have a certain percentage of elderly that are living independently. Well, if you're living on the 4th floor and you're in a wheelchair, even though you might be technically marked as living independently, you're not living independently when there's a disaster and you can't get down from the 4th floor. Lack of information from media and TV, lack of support, and lack of hearing, vision, and strength. Another vulnerable population that I found are children. Children experience family separation. They need pediatric nursing available, which they're not always getting firsthand. They have the inability to understand and trust, and they have food insecurities, which we've seen during COVID. Disabled and chronic illness are also vulnerable populations during a disaster. They lack transportation. Sometimes they're needing medical devices that aren't available. Pregnant women need to be at the hospital if they're close to delivery. They also experience food insecurities. They spend a lot of money on medical bills. They don't always have a lot of money for food. Medical care and follow-up ends up halting, as we've seen with COVID. Mental illness is another vulnerable population. They experience more homelessness, more poverty. Their conditions exacerbate due to confusion of what's going on around them. Low income is a vulnerable population during a disaster. They also have food insecurities. They lack money for transportation, housing alternatives, no car to get from the disaster, or they can't be tested. We've seen that with COVID. They don't have cars to go to the testing sites. Sometimes the bus is not running in a disaster, and they suffer from unemployment during a disaster. Immigrants and refugees are also vulnerable. They have language barriers. They experience poverty. They come over to the United States with nothing. They lack primary care. They don't have good housing, and there's racial tension and incivility. The LGBTQ are also a huge vulnerable population during disasters, and what they experience mostly is discrimination. The name calling is a lot of what happens, and just the social uncomfortableness that the nurses have. Rural geography is the last vulnerable population that I found. They have lack of transportation, lack of supplies, food insecurity. They can't get to the grocery store. The caregivers may not be available or coming to their houses. Phone and electricity outages can occur. The National Guard or FEMA are unable to rescue due to being so remote. We saw that with Hurricane Ida. And also unable to get to the hospital. And my references are there. You can print those out if you need to. Thank you very much.
Thank you, Karina. We will now move into the panel presentation, and I will introduce these nurses in order of their presentation. First is Peggy Weber. Peggy is a retired nurse and continues to use her nursing skills on several nonprofit boards in Dane County, including a second term on the Wisconsin Center for Nursing Board of Directors. She remains on St. Mary's Ethics Board and facilitates grief and cancer groups in the area as a volunteer. Welcome, Peggy. Next, we have Kelly Cruz Nellis, who is part of the Wisconsin Center for Nursing team. The team is responsible for the development and implementation of the Wisconsin Nurses Respond Now priority training and program. Welcome, Kelly. Following Kelly is Kirsten or Kiki Lazama. Kirsten has an amazing background in public health nursing. She currently serves on the board of directors for the Greater Milwaukee National Association for Hispanic Nurses, and she is representing them today. She has transitioned her knowledge and expertise into nursing education and is an assistant professor at Alverno. Welcome, Kirsten. Our last but not least panelist is Victoria Coyle. Vicki is a nurse educator and is advanced to the role of Dean of Health for Gateway Technical College. Vicki currently serves as the president of ANU, Administrators of Nursing Education of Wisconsin. Welcome, Victoria. Each presenter will have a few minutes to provide some introductory remarks on their thoughts and activities they're involved in as it relates to nurses and emergency preparedness. Thank you all, and Peggy, I will turn this over to you.
Well, good morning, everyone. This is just a hoot. This is just a hoot, let me tell you. I'm happy to be with you, and I'm honored and humbled to represent WCN and Barbara Nichols on this panel today. I'm down in sunny Arizona in a trailer at a KOA campground, so God only knows if this is going to continue on for a couple minutes. But if I lose you, I'll try to get back on if I don't blow the computer up. Anyway, as a review for most of you, the Wisconsin Center for Nursing, WCN, was created about 16 years ago to alleviate the public health crisis caused by a shortage of nurses, and to engage nurses and healthcare organizations and government agencies to work together as collaborative partners to ensure an adequate, competent, and diverse nursing workforce for the people of Wisconsin. WCN is a 501c nonprofit. Now, WCN is focused on 5 core nursing workforce areas: data, education, diversity, leadership, and partnerships. WCN is supported by funding from the Wisconsin Department of Workforce Development, DWD, through nursing licensing fees and individual donations. I have to say, when I started on this board, why at 74 years old would I be on a nursing board? It's because I believe in nursing and support and empower nursing, and I want to stand behind our nurses. But when I started on this board, there were so many initials, and when I heard DWD, all I could think about was oil. Like picking up gas oil for my husband for the car, or the truck, or something. So, learning all these initials has been a hoot. So DWD supports us, and they're good people. They're good people. So the vision of WCN is nurses in Wisconsin speak with one voice for the nursing workforce issues. Imagine that. We're speaking with one voice for all of the nurses. And our mission is to assure an adequate, well-prepared, and diverse nursing workforce for Wisconsin. Our core work is around data analysis and trending for the RN and LPN workforce, with exploration of expanding this and other healthcare workforces like the CNAs and the MAs. So looking at the data analysis, when I first came on this board, I thought I was back working on my master's degree, because I really needed to function at a higher level, like get my brain working again in critical thinking. And the work that WCN does really looks at what's happening in the nurses around the state. Presently, we have 11 different nursing organizations represented on our board. And that's fascinating. 11 different nursing organizations have a say on with us and with our work. We have an ongoing communication and dissemination of workplace reports to policymakers, healthcare organizations, and academic institutions. In 2020, over 90,000 RNs took the nursing survey. And this survey was analyzed by a UW research team. And our nurses in Wisconsin indicated their lack of pandemic preparedness, which is a workforce issue. This information has been passed on again to healthcare policymakers, healthcare organizations, and academic institutions. Our nurses also identified that they are not prepared for caring for vulnerable populations. Nurses stated their workplace employees had trained them for emergencies, but not for a pandemic. We also knew, not for the pandemic. WCN took these 2020 survey results, clearly heard the nurses' need for education, and went to work exploring how we could meet our nurses' express needs. An emergent curriculum needed to be developed for all nurses addressing pandemic nursing, the negative health consequences experienced by desperate and vulnerable populations. As you know, vulnerable populations are at greater health risks, poorer health outcomes, and have higher death rates, as Emily just mentioned. A Bader grant was applied for and received to develop such an extensive curriculum. We hired the National Register Nurse Care Manager Training Center to develop this curriculum. And Kelly will be talking about that shortly. We then received a grant from Robert Wood Johnson Foundation to expand the course statewide. We did offer this educational course first in the Milwaukee area because of their higher number of COVID cases. At the time, 73% of Milwaukee County COVID deaths were Afro-Americans. We also knew Black, Latino, and elderly were catching COVID at double and triple rates and dying from it. So WCN has designed the Wisconsin Nurses Report Now, the Wisconsin Nurses Respond Now education initiative. It is an online priority training project to provide relevant, high-quality education for our nurses. It covers COVID-19 pandemic disparities, social determinants of health and equity, all concerns expressed by our Wisconsin's most vulnerable population. We know that nurses express the need for this education, and nurses must be able to receive this information easily in a way that allows them to rapidly transform this information into practice very quickly. Our hope is to transform nursing in order to improve healthcare and build health, equality, and equity. We did not know at the time that the future of nursing 2020-2030 would focus on this need, addressed clearly by our Wisconsin nurses. And the number 8 recommendation of the future of nursing, enabling nursing to address inequities, strengths, and protect the nursing workforce during the response to public health emergencies, would already be in action in our great state of Wisconsin. So that's just a very quick summary of WCN.
Thank you so much, Peggy. Kelly, if you could share your thoughts.
So good morning, everyone. I'm happy to be on the WCN team that worked on this project with Dr. Barbara Nichols and Suzanne Bottom-Jones, who was our innovation specialist. And as Peggy described, we identified the gap that nurses were experiencing. And this was occurring at the same time that you could no longer deny that populations in Wisconsin were experiencing dramatic negative consequences, not only more illness, but more death. And one of the things that we did as we moved to create a priority training that would help to address and close the gap is we went directly to the grassroots organizations that were providing care and trying to get the services needed in the inner Milwaukee area. And from there, we were able to identify not only that we had the correct populations identified, but we were also to determine directly from those organizations who was providing the care, where they were going for care, where the services were available to them. This then allowed us to reach out to those organizational leaders that were involved in delivering this direct care. And this went very quickly because the organizational leaders, the nurse leaders, were identifying also that they needed help with this issue. That this public health emergency in the form of this pandemic, which was new, with limited information and dramatic visible disparity, that there was a coming together, collaboration, if you will. And so we were able to help them identify where those frontline services were and help them identify the nurses who were most directly working with those populations. So through the Bader Foundation, we received a pilot grant and were able to offer scholarships to those nurses to get this pilot off the ground and evaluating it constantly. That did we match the knowledge needs with the practice needs? Because the whole goal here was to be able to gain new knowledge and rapidly turn it around and apply it back into practice. And that's something that I've always been really committed to, so I was pretty excited. And we found out pretty quickly that, yeah, we were pretty close. We made some tweaks, and we, of course, made some adjustments because as the pandemic unfolded, we had more information. But it was an important piece, and to date, we've had almost 80 nurses complete the training. We did receive a Center for Champion Nursing Innovation Award for the second phase of development for this curriculum, and we're really proud of that. And we weren't surprised to see that number 8 was a recommendation because we feel like we played a role in helping to shape that somewhat. So we were pretty excited about it. As Peggy said, this was very well received by nurses, and the nurses who have gone through so far have been in these frontline positions in both urban and rural settings, in acute, primary, and long-term care services. They have had a variety of roles in being involved in that. And all of the vulnerable populations that Karina referred to, we were able to have nurses they reported to us the populations they were working with, and we learned that we were in fact matching and able to make those connections. One of the things that I think was an important piece, because when we talk about this issue, there is really important conversation going on about what needs to happen in our academic settings. And we feel that there's a parallel track to that in what's the knowledge that the nurse already in practice needs, what's the workforce development need. And so to be able to kind of come at that in a two-pronged approach, I think is a really key thing. So I have posted for you not only, as Karina alluded to, I've posted the highlights, I've posted the recommendations, and I've posted number 8 for you so that you can read those summary sheets really quickly, because I agree, 500 pages is a lot, but I read it too. I go through it all. So, it's valuable to me. One of the other things that I would say is that when you look at this, you will see that there are practice outcomes specific to the nurse, and there are organizational outcomes specific to how the healthcare organization can benefit from a better prepared, better informed workforce. The other thing that we did with this is we really tried to, I don't know if you've seen this paper, but I think this paper has been really important. And it comes from, it's a living document. This one happens to be from the National League of Nursing, from their Board of Governors. But it's a vision for integration of social determinants of health into education. And I use this all the time. And I think it's a really helpful piece, because what it points out to you is that currently many of our practicing nurses have not had the opportunity to really learn about health equity, to understand really truly what diversity means, what it means to be vulnerable and at risk. And what we learned in our evaluations is that social determinants of health, while nurses had heard of them, it was really very new for them, and many of them had never incorporated that into their practice. So one of the things that came out of this is not only were they provided with, overview content in the form of a lecture, but they were also able to come away with a set of evidence-based downloadable resources that they could take with them back into practice. And then they were provided and are provided with a toolkit. And the toolkit is a practice toolkit. So in it, you will find validated tools for quick assessment of social determinants. You will find information on how to enhance your care coordination skills, how to manage care transitions, all of those pieces that we know have the ability to impact health outcomes so dramatically. The program overall continues to be very well received by nurses. We continually, the satisfaction with the program is between 80 and 90%, which I think is like amazing, because having taught for a number of years, I get excited. You never know, right? But what we also found is we asked some qualitative questions on our evaluation. And one of them was, how do you plan to use your new knowledge in practice? How do you plan to use this knowledge in practice? And for many nurses, it was a connection, connecting, oh, I never thought about it this way before, or helping them to be able to look at someone who's struggling or perhaps has been readmitted in a new or different way, wanting to talk to colleagues about this, wanting to bring this back to their team, wanting to find out. We learned that in some EHRs, for example, there is a social determinants of health assessment, but it's never been turned on, or the nurses weren't made available or made aware of it. And so we were able to address some of those even most fundamental pieces. We also asked the nurses, what barriers do you see in being able to move this into practice? And time, of course, would be one we would all think of, right? Overall, nurses felt like that they were pretty supported by their organizations and their nurse leaders. However, they had concerns about how they would find other nurses who also were committed to this issue. So they wanted to know in their organization, were there other nurses who were working on this? Was there a way for them to be able to come together and talk? And then they also were concerned about, how do they integrate this into teams? And then the final open-ended question we asked them is, what resources do you need? And a big one really had to do with wanting to stay connected, wanting to be part of a solution, wanting to be part of a bigger response, not only within their organization, but within the state. So I know for Barbara and I, we were pretty excited about that, because we're having a lot of good discussions right now about how do we build these health equity champions within the state of Wisconsin's nursing workforce. So I've included for you also a program description, so you can take a look at this, and you know how to reach Barbara at WCN. I'm also available to you. If you have any questions, feel free to just shoot me an email. But I'm going to transition my time now to the next person. But thank you so much for letting me share the outcomes related to this. I should say one other thing. We did pilot most recently in Illinois. And we wanted to really be able to assess this transferability and creating a more universal curriculum so that more nurses across the country may potentially be able to tap into this. And we're pleased to report that that was very well received also, and that we were able to meet their learning needs as well.
Thank you, Kelly. Kirsten, it's your turn.
Good morning, everyone. For immunity reasons, I'm going to keep my mask on. It's not that I don't want to show you my face. But I am here representing the Greater Milwaukee National Association of Hispanic Nurses. And so most of the considerations that I'm going to bring forward today do have that background, but of course I can't get away from being an academic. So you're going to hear some theory-based things as well. So I apologize for that in advance. But NAN, as we call our association for short, our mission is to impact community health and wellness, mentor youth, and encourage pursuit of careers in nursing, and to inspire and guide and promote Hispanic nurses to seek higher education and leadership roles within healthcare systems and the nursing profession. So you'll kind of see how that translates into the information that I'm going to bring forward today. But before I say that, I will say that my answers or my recommendations that I'm going to be bringing forward are based on an upstream approach. So while these answers might have significance, right? They might hold merit. They are definitely not the easy route. They are definitely not the easy answer. They're not the convenient answer. So we really can't talk about a disparity lens without talking about inequities, right? Disparities are the result of the inequities. And so we would be ill-informed if that wasn't part of our consideration. We can't approach these types of situations like public health emergencies like we've been experiencing with COVID with strategies that are in a vacuum. And so the presenters here today have mentioned social determinants of health. And it goes beyond, right, saying, oh, we need to consider those, right? Well, we know we need to consider those. But like Kelly had mentioned, what does that mean, right? We say we value health equity. What does that mean? And so really, it kind of comes down to two pillars that I bring forward from some experiences that we've been a part of as far as addressing this public health emergency. But that is collaboration and representation. And so one of the collaborations that NAN has been a part of since kind of like the end part of last year is we have been part of a grant with the United Community Center in Milwaukee. And that is called Venciendo la pandemia con la vacuna, which means ending the pandemic with the vaccine. So it's to promote vaccine acceptance among the Latino community. And really what that looks like is a multidisciplinary collaboration, because if we're talking about social determinants of health, we can't just talk about healthcare. And so this has been an extremely successful vaccine promotion effort, so much so that it was extended for an entire year more. And so this includes non-UCC, which is the United Community Center, the LMSA, which is the Latino Medical Student Association, partnered with the Medical College of Wisconsin. And so a lot of this is really boots on the ground work. So I'm also the Community Outreach and Service Committee Chair for NAN. And so really it's walking our walk, right? It's saying we need to be out in the field, right, doing what we say that we need to do. And so when I mean representation, right, we talk about NAN's mission, and that's leadership in healthcare, right? We know that when somebody sees somebody that looks like them, that's important. And even so much more for healthcare. Because if we talk about vulnerable populations, in particularly historically vulnerable populations, historically marginalized populations, we can't exclude the idea of or the concept of mistrust that exists. So when we look at health promotion, oftentimes we're saying, what's best practice, right? What can we do? What theory can we bring forward? What framework? That's great. Absolutely. I'm all about evidence-based practice. But we have to establish the trust first, right? We have to go back and say, right, how do we really meet you where we're at? Because we can come at you with our fancy theories, our fancy frameworks, but if it doesn't resonate with you, if it's not relevant to you, it's not going to make a difference. So that's the main consideration that I would say to bring forward. Right, it's also too, right, about self-efficacy. So, right, health belief model, like I mentioned, we talk about people seeing people like themselves. They're more likely to trust. They're more likely to uptake that message and say, you know what, They come from where I come from. They understand what I'm going through, right? They understand the considerations that I might have. Cultural competency goes well beyond having something translated into Spanish or translated into Korean or Burmese, right? It means having somebody there that speaks your language. The sigh of relief that I personally have seen when I approach somebody and say, ¿Cómo le puedo ayudar? How can I help you in Spanish? Versus having a translator, that barrier instantly crumbles, and it means so much, right? And we know some of the best boots on the ground work for health promotion comes from word of mouth, right? So what happens? That person goes back and says, hey, you should go to this vaccine clinic. There's a whole bunch of nurses there that speak Spanish, right? And so, right, it sounds like a very small component, but it means so much and it holds so much weight. Right, and the considerations of saying, okay, maybe we have these best practices. But for example, the thing that we were seeing, the example I'm going to bring up in the beginning of the pandemic when we talked about isolation, well, one of the recommendations was don't share a bathroom with someone if they're in isolation, right, if they're infected. If anybody's been to the south side of Milwaukee, you know those houses have one bathroom. So then what, right? Also things like, okay, well, if we're talking about maybe some of our undocumented population, how do we resonate with them to become vaccinated? Well, you'll miss less time from work, right? We know that sometimes they don't have time that's paid off from work. They don't have the luxury to work from home. So even somebody just understanding that, right, whether or not that's in a boots on the ground approach or in a policy, which NAN is also very involved in, is also, right, very important to consider. And so much so, right, in that facts are great, but stories are better. Right? We can say, we know this is true. We can give you these numbers. We can give you these facts. Nurses, we love facts. We love evidence. But that doesn't resonate with somebody. It doesn't resonate with their values. It doesn't resonate with their emotions. And we know from multiple health promotion standpoints, right, we have to resonate with someone's values and their emotions in order to promote, right, that behavior that we're looking at. And so with representation, I'm just gonna go back to that for a second and then I'm almost done, I promise. We really wanna make sure too that that is being done because a lot of the times, historically, it's vulnerable populations are having decisions made for them by the majority and not by them. And so having that inclusion in policy making, in program development, in community collaboration, communities are always their own experts. And that's something that I would definitely say, right, going forward is always consult with the community on multiple occasions, especially as we see COVID evolving rapidly before our eyes. And so really the answer again is not how do we react in a health emergency, a public health emergency. It's what are our structural systems in place? What are we doing to prevent those inequities? Because that's the answer for the disparities, not the other way around. So again, it's the difficult answer, it's the inconvenient answer. But with more and more engagement, I tell my students all the time, engaged communities are healthy communities. And so that's the ultimate way to start. I'm sorry, academia is terrible.
I think we could talk about this topic forever, all day if you
Yeah,
could.
I'm sorry.
Last but not least, Vicky, if you could please share your thoughts.
Coyle, and I'm the president of the Administrators of Nursing Education in Wisconsin. I also serve as the Dean of Health at Gateway Technical College, which is one of the 16 colleges within the Wisconsin Technical College system. Today I'm here on behalf of ANEW. And what ANEW is an organization that was formed in 2011 that's a collaborative of nursing administrators from all levels of nursing education. Our goals are to create a quality, consistent nursing education throughout the state of Wisconsin and to address the nursing workforce. Part of the initiatives with ANEW recently have been to not only continue to provide a nursing workforce, but also recognizing that within the next 10 years, 56% of nurse educators plan to leave education. So we're also looking to increase the level of education of nurses throughout our state to fill that gap of nursing educators to continue to provide nurses to work the floors for us. So part of what the pandemic and what makes this really important for us is that when COVID came along and so many of the hospitals and clinical organizations really closed their doors to students. And what we know is that nursing students, a really important part of their education is that clinical bedside care and that those community health services, and preparing them to go out into an even more complex workforce. And when I say even more complex workforce, we could probably go on for hours about that because we have nursing students who are graduating from nursing school with less hands-on patient care. A lot of them have done a majority of their clinical either with virtual simulation, with telehealth, and on Zoom, and using high fidelity simulation in the labs. So we know that they have less bedside care experience as they graduate from nursing school, but also they're entering into a workforce where the practicing nurses are more stressed. Some of the experienced nurses have left the workforce, some because it was time to retire and some because it was really close to time to retire. And so they decided it was time, right? And so they're having shorter orientations because the hospitals really need them to be working in the capacity of a floor nurse. And they're also entering into a more hostile environment because of the stress level of the nurses practicing at the bedside. And then we're going to add to that kind of the social justice and the systemic racist issues, and having to prepare these nursing students to have difficult conversations and to have those crucial conversations. So we're finding that at our level in education, the things that we're really doing is, one, we definitely are supportive of including the social determinants of health into the curriculum in every level. There's a place in every course in a nursing curriculum to include that, but also preparing students to have those conversations and to have a comfort level. And that all starts with training the nursing faculty, who many of them have been in the workforce for a long time and may themselves not be comfortable talking about diversity, equity, and inclusion. Also increasing the number of faculty that look like our patient populations and look like our student populations. So having faculty, minority faculty and male faculty members in the classroom so that students can see themselves succeeding and see themselves becoming nurses and being a voice in our nursing profession in Wisconsin is really important. But another important thing is having those mentoring programs so that even if we can't right away meet that and have the nursing faculty of minority populations in front of the classroom, but having professional practicing nurses who are there to give them professional advice and to cheer them on and to be that listening ear when they are having troubles at the bedside. So I see this as being a really important issue for nursing education, and definitely from the perspective of the Wisconsin Technical College system, wanting to take down those barriers that keep our minority students and vulnerable populations from being able to pursue nursing education, but also to provide that nursing workforce at the bedside to understand those social determinants of health and to be that person that can be the listening ear for a patient and be that trusted person that the patient can talk to about their health inequities, and adding, having those social determinants of health and health equity questions part of the nursing assessment, and having them recognize that in the casual conversation they might have during their assessment with their patients.
Thank you, Vicki, and thank you all for sharing your wonderful insights and your expertise. I have a few questions for the panel that I will let you all discuss and answer together. If we could take just a couple of minutes. The first question is, what are the awareness categories or topics and skill sets that can be applied in supporting nurses in their engagement in this work? Anyone want to go first?
I feel like I talked a lot, so I was trying to share it a little bit. Examining self-bias. I wouldn't be representing Alverno very well if I wasn't talking about self-reflection. But examining your own bias, this is something that I force students to do every single clinical practicum. And mostly so because we're so embedded sometimes in our biases, because we all have biases, that it becomes difficult then to even conceptualize ways of doing things differently that promote health and promote equity, more importantly. And so as many times as you're able, even for practicing nurses, to have those opportunities to have safe spaces for people to be vulnerable and share those biases so that they can work through them, is so important. I can't tell you how many times I've heard from students, you know, I was working with this nurse and here's what was said. And I said, so what would you say in that situation, right? And, you know, students are always timid, right? They don't want to speak up. And, but I encourage them to do so because, right, it's about creating that culture of equity. If we don't establish a new social norm around addressing biases and, for lack of a better term, calling people out when that needs to be re-examined, we're not really doing the hard work that we need to be doing.
I would echo that. And the safe space piece, I think, is really important because 90% of RNs and what is it, Barbara? 93% of RNs and 90% of LPNs in Wisconsin are white. And so when we were working on this project, that is one of the first things I asked for. And we have a lot of funny stories, but I'll go, okay, just a second. I need a safe space. I got to just say this out loud and help me with my thinking because everything has always been geared towards me, right? And so it's not that I don't have a commitment to working with vulnerable populations because my entire career has been on building clinical services and working with a variety of different groups. But it's the opportunity, I think, it's not a penalty, right? It's an opportunity for me to really be able to think differently and to model that for my colleagues. I think that's also a really important thing. That implicit bias is something that came up that the nurses commented on a lot, that they'd never really thought about that, that was new to them. They also didn't really realize, several talked about the fact that they weren't aware that we had a social justice piece. And some also commented that they didn't realize that we had an ethical commitment. So there's some professional pieces there that I think would be important for us to bring back out and make more visible again, because that was really clear. This social determinants piece and the upstream thinking, I love when you bring that up, Kirsten, because upstream thinking gives you this opportunity to think about things differently. You know, and I cannot tell you how many times when I work with nurses and I say to them, and these are nurses in practice, I'll go, all right, we have all these supports and systems built in at the bottom of the river. But do you know anybody who's ever gone to the top to see why people are falling in the first place? Because this is you. This is your job. This is what we need to be doing. So maybe when you have that non-compliant patient, you could think about this a little differently and figure out, why did they have trouble? Why were they falling in? What was happening? And it's sort of a light bulb moment for nurses. They get very excited about it. And it's almost like in some ways you're giving them permission to be able to do that because they've known that it hasn't been a match for them necessarily, this medicalized way of thinking that we have about chronic illness. The other thing that came out a lot is, I'll give you one really basic example. One of the nurses wrote, it never occurred to me to ask about food. Now, as a former public health, I don't know if you're ever a former public health nurse, but as a former public health nurse, I kind of went, how do you not ask about food, right? But it also is really telling to me that in our systems today, nurses are asked to be so task focused. And there's so many things that need to be completed in a day. And we're so focused on an acute model of healthcare that we lose track of the fact that people don't live their health in the hospital. They live their health in their community. So this piece of being able to go to the community and connect with the communities, I just think this is a really important component.
On our end in education, we have formed a diversity, equity, and inclusion department at our college, and we have a VP of diversity, equity, and inclusion, as well as, I'm really proud to say that two of my nursing faculty head our diversity, equity, and inclusion committee. But what they've done, first, what we did as a faculty in our School of Health is we did a group read of Crucial Conversations and really went through, and they did scenarios where they were put in difficult situations and had to have difficult conversations. But now what we've incorporated into the culture of our college is Crucial Conversations on Zoom so that students, staff, and faculty can join. And every crucial conversation is a specific topic. And it's not always related to equity. It's not always related to racism, but it gives that opportunity for faculty, staff, and students to all come together and have those conversations in a safe environment. And it gives them the opportunity to hear each other's stories and hear situations where they have felt uncomfortable or offended. And it's been a huge wake-up call where I've even had nursing faculty that have shared experiences where working at the bedside as the RN, the patient will ask them to get their nurse because they assume that they're the CNA. Or the sharing the stories about how uncomfortable they are when people want to touch their hair, like little examples like that people may not think of, but it has overflowed into having that practice and sharing those experiences and taking that into the classroom and being more comfortable and having difficult conversations and addressing biases as they come up immediately, and really arming them with the skills and the comfort level to do that because they feel supported from all the way from a VP level, from an administrative level, and a faculty level. So I think the more we do that and the more we put on our health end, we do have simulations that bring different cultures into it, language barriers, and really putting the students in those situations that they may not be able to be put in the acute care setting, or they just haven't had that opportunity yet.
Thank you.
Is even if you never attend to one, they're going on. It changes the culture right there,
Yeah.
right?
Yeah.
That's very cool.
My next question is, what do you see as the opportunities and barriers to achieving nurse awareness and skill sets?
For this, I feel like nurses over the past 10, 15 years have been taught about different cultures, and we're going to be working with different cultures, and this is what we do while we're working with different cultures. But we do need to practice, and we do need to feel comfortable walking into that room full of, let's say, a whole room full of Asian people who, and you're thinking, oh, I had this in class. I know some of the things, but you didn't really ever have a chance to practice and to actually hear their side of how they want to be treated.
And I think the arrogance sometimes that somehow we know, right? And we don't know anything. And so being able to really work with our colleagues and our students to encourage them to ask the patient their experience, to talk about their experience, because everyone's an N of one. I mean, really, I know we all kind of participated in that cultural diversity piece, right? Where, here, if you're in this group, this is what happens. Hopefully we're moving away from that we're recognizing that it's much more broad and much more diverse.
I think we have to be really careful not to put each other
Yeah.
into the textbook version too.
Yeah.
Because what we do know is that my patient may be Chinese, but she may not follow, she may be more Americanized. And I think having that comfort level and expressing that interest, asking those questions in a way that portrays that you're genuinely interested in knowing what their culture is and what their preferences are. And, taking that and trying to provide them with care that is culturally competent, but also using it as a learning experience and knowing that just because that Chinese patient you took care of had those specific nutritional needs, it doesn't mean that your Chinese patient in the next room is going to want the very same thing. And that's a very dangerous assumption to make. And so I think always being open to hearing either your patient or either your coworkers, because if you're working with a diverse faculty or a diverse nursing group, then you want to make sure that you're also honoring and including their cultures.
I would say some really good frameworks, of course, frameworks to look at, to utilize if you're wondering kind of where to start and what to use in beginning those conversations. Motivational interviewing, ORS, if you look that up, that's a really, really great launch point to use if you're not familiar with it. Otherwise, what I recommend to my students is have just a couple sentences that you keep in your pocket. Things as simple as tell me more, help me understand. It's really that, right? It's really that simple, because this goes back again to establishing that trust, right? If you bring yourself down off that pedestal of medical professional, I'm a person just like you. I have a family just like you. And again, modeling, I think it was brought up a lot. I try to do this as much as possible with my students. So they're like, oh, it's not, big bad communication, right? Where they feel like it has to be this formal thing. And it's like, you're taking care of people, right? How would you talk to your parent about this? How would you talk to your friend, your sister, right? Your brother? So I think that that's really important, right? That we're not the experts in the community or of the patient, they are. And so we should always be consulting with them.
Thank you. Did you have something to add? Oh, okay. My last question is, what do you think the WNA should work on together with the Wisconsin Center for Nursing to advance this work?
You're all looking at me.
I think actually Kelly's program is a great way to start. I was thinking of that just when we were doing, we met before this, and I think even having my faculty have that kind of training so that it flows over into their teaching in the classroom and kind of raising that awareness, but also, boy, I don't know about you guys, but I want Karina's email address because I think her presentation is great because it really adds to the thought process and the recognition of what our nursing workforce is going through at the bedside right now.
I also think the inclusion of different and diverse organizations is also going to be important, just to kind of reflect that representation that's really needed. Our bodies and our communities don't read the textbook. So as much as we can be informed, right, and have an idea, it's always different. It always presents different. And we need those perceptions. We need those realities in order to really push an equitable agenda forward and have meaning behind that, not just the word.
I see a real strength in collaboration between WCN and WNA. I think the leaders of both of those organizations and the members who are a part of it represent such a robust and varied and comprehensive and connected network that it's a tremendous opportunity, I think, to really be able to come together and to discuss. And I'll just plant the seed again, but I love the idea of us coming together to really create nurses who feel confident about being health equity champions. And especially, our nurses in practice being able to fill in those knowledge pieces so that they have more confidence, because that may enable them to be more confident in precepting or mentoring our new nurses coming in. And I just see a lot of ways to work together.
Whoever's back on, I'm on phone, or can you hear me?
We can.
You can't? Oh, good, good,
Yep.
good. Well, my video went out, but I agree with what I was able to hear from you, but I think we have to listen to the nurses. The nurses spoke in the survey. They said what they needed, and we've got a great partnership going with WNA and WCN, and you know, we speak for all of the nurses. So, you know, they said what they need. So now it's up to us to meet that need. And working together, we definitely can do it. And with the people in the room, we've got some great nurse leaders I could see. So let's go for it.
All right. The last step in the forum is for the audience to share recommendations for the WNA, to engage, to support preparing nurses to respond to public health emergencies in the health disparities lens. So if anyone has, it's such a broad topic, but if we could narrow down just a few points, if anyone has anything to share. Margaret?
I'm Margaret Schmelzer, and I've had a 45-year career in public health and teaching at UW, et cetera. And I told Gina that your panel is like a tour de force. It's one of the best panels I have heard. And I just have some recommendations for you.
Please share.
Huh? Hold on. No, I can just, a couple of things. Peggy and many of you at the panel today talked about the fact that professional nursing has one foot in the on the clinical realm and one foot in the public health realm. And that positions us to be, and then with people's trust in nursing is really an advantage, but we have to explain this advantage. Okay. Secondly, the state health department initiated after some years a program which I recommend you look at called Resilient Wisconsin. And it's a website. And I don't know how well WNA or WCN are connected to that, but there are some key actors in there. Third, I got called out of retirement a couple of times since I retired in 2013. But most recently I was asked to write the COVID report for CDC, which is a 350-page report. A colleague of mine did this. It's a required report, and it's sort of sitting. And I'll tell you that the state health department, who I know very well, is under tremendous stress. So are the local health departments. Everyone's deployed to COVID. Okay. So that's just a thing they're dealing with. And as part of that report, I want to commend, because I know stuff you probably don't know, and the public definitely doesn't know from that report, is in phase 2 of the pandemic, which started in about July through last winter. I would sit there and read documents after documents online, searching the department's documents. And no one knows the story of what the hospitals and the healthcare system face. No one knows this. We know vaccines, we know deaths, we know case counts, we know prevalence, incidence, the whole thing, but no one knows the story. And when we finished, I told the secretary's office that her communication team should take excerpts out of this and share this with the public. Okay, so I, as a retired nurse, just go, oh my God, what you guys faced. Okay, now as for disparities and equity, that was also something we reviewed, and I applaud this work on health equity. And I've been at the social determinants of health for about 15 years of my later years in my career. And there are a lot of models for this. And I think my favorite model, even though we ended up using the UW model, which is real scaled down, but look, I love this Evans and Stoddard model. It came out of England, was advanced by the US Institute of Medicine. And for a practicing nurse, an administrator, our community organizations to look at that Evans and Stoddard model, it's so graphic. And it looks at all the factors that impinge on equity, that create disparities, and how housing and food and transportation and crime in our streets and all this stuff influences the environment. So just with the short time I have now, I told Barbara and Gina last year that the Public Health Foundation in Washington years ago established what's called the Train Learning Network. And I know, and I contacted Joe Cordova, who's a friend of Gina's and mine at the department, and he sent them information. So you can take your programs and get this not only on the Train Network, get continuing education credits for this, but like when you talked about working with Illinois, it could be a joint thing around the determinants of health, a joint effort around equity and disparities. So I recommend you look at that. And and another point on Resilient Wisconsin, it's all about trauma-informed care and the trauma and the toxic stress that our families, especially vulnerable population groups, have. And a final thing I would just say, being a systems person like you guys, Gina called me out of retirement. And one of the things we did was we published a framework, a patient-centered team-based care framework. And we vetted this with multiple disciplines and organizations in the state a couple of years ago. It's on the WNA website. But one of the things, this is such a cool model that Gina has advanced. And there are these components in there. And Eileen Smith, who's like a brilliant physician, public health person at UW, we met with her. And she talked about organizational culture, okay? And that's a component of this model, that if you want to advance, so in this case, team-based care, doctors and nurses and PTOT, patients can do this. But if the parent organization isn't in support, that isn't a part of their culture, these efforts fail. I have witnessed this in the state health department where we don't have the organizational culture looking at efforts. So we have to think about that, even if we look at it at institution by institution, teaching nurses about social determinants of health, including myself, or equity. We do it, we add that on as an additional burden, but we don't have the infrastructure support that a department of nursing or a health department or a hospital can offer to support that as a means to systemic change in thinking and how we do things. So I could give you more. And finally, if you need my help, let me know.
We will. We know where to find you.
Dr. Maureen Green again. I had been trying to read one of the chat notifications, and of course it's 25 feet, so I could not read it. But one of the portions of it that I could read, and my comment is in any of these teams to always have a lay person that can comment on the social determinants of health. So I just want to bring that up because it's extremely important. When I did palliative care services for the hospital, when we had team approach, of course, we had social services involved. We had religious services involved. We had nursing services and medicine. Whenever I would be doing the conversations with the family, I always wanted to start with, of course, they knew we were having a palliative care conference. I always started with them. Not that, do you have any questions, but really, how are you feeling? So we always initiated that. And unfortunately, when you don't have complete team approach, because of course the doctors wanted to just fly in and discuss what the palliative care concept was at that time. You missed some of that robust information that we got from the initial question of how are you feeling, how are you doing, things like that. So it's really important, and I think very challenging, which was just commented by Margaret, is the sense that it's hard to get your organizational structure to give you the time that's needed to really do this effectively as nursing staff. We do have a multidisciplinary team, and we do kind of fall to the social services department, case management department to handle some of these things. And as a practitioner of telehealth and in-person home visits now, under my research, which is transitions of care, I think even more recognizing that this care needs to be done in the community. So we can't really handle this in the hospital, and don't ask us to do it during COVID, because we are in rescue mode right now. But we have known this, that we can't move it. And I'm very excited about the insurance companies I work for now. I don't work for the insurance company, but I work in conjunction therein. And Network Health here in Wisconsin has a new SNP program, SNP. So they actually add on for certain health individuals in Medicare and Medicaid in certain areas of the state of Wisconsin, certain counties, they're northern and central, including Dodge, that meet the SNP requirement to add on services like transportation, med management, other determinants of health that we were talking about. I'm sure it's pilot and of course relative to where Network Health originated near Green Bay, but this is very important expansion of the care delivery model in the health insurance programming. And within that, as nurse practitioners doing this work, have to address some of these SNP criteria on relative patients, these special needs programming. So I think we have other individuals that are meeting the social determinants of health in a more appropriate area than you're talking in a clinic setting per se, or a hospital setting. We should all know about these needs: food insecurity, financial distress, things like that. But the real work is in the community. So that's what I need to stress. And it's not necessarily public health, it's strategically using nursing services at the highest level of their education and community service.
One of the things that has come available in the last couple of months is the use of Z codes for identifying social determinants. It seems, although it says it can be used across all practice settings, it seems to be more related to the hospital and trying to link that to quality outcomes. Again, I'm just learning about it. I just wondered if you had any experience with that.
Most of the Z codes that we're currently looking at or documenting are relative to the personal history of, and those might be more in the diagnostic area or not necessarily in an area of a Z coding an issue. However, the documentation that's unfolding, we have a number of competing online methods of documenting this stuff for insurance companies. And I will say there is some merger between the insurance companies. There is a little variations between their charting for United Healthcare versus Network Health versus Anthem. And I'm talking our central states, the insurance companies here, because as a nurse practitioner, I only see clients in the state of Wisconsin. The clients cannot be in Arizona. They have to be in Wisconsin when we do the interview for emergency purposes. So there's some protections here, but in terms of using the Z code, there's an area of the documentation that picks up on specific areas of determinants. That's why drilling into the data and seeing what's going on, because even though I am commissioned to be able to elevate situations of concern to adult protective services, to other avenues, I have to know all the community services relative to the districts that I cover. And doing those kind of referrals are extremely important. And then we have a background of getting case management involved, and we're still working on that. I've been consulting with the firm in terms of getting that information back to the practitioners is very important. So they're starting that circle, but I just wanted to mention insurance companies starting to answer to the special needs programming of clients, which is extremely important.
Thanks. I bring that up because if you have a chance to look at the toolkit that's accompanies recommendation number 8, the Z codes are mentioned in there.
Mhm.
And so, like I said, information is just becoming available, but
Z codes
it-
are not compensated though.
no, they're not. They're tied to quality outcomes and
But in the background of building the electronic health record for this type of work, the Z codes are matched. So it's just
Right.
something that when we tap into that, then we can start to address. And I think when I talk to this firm that I work for, is the fact that we have to start addressing the clients that need the higher level of care than those that need lower level of care. You know, there's a lot of individuals that say, why am you coming to the home? I see the doctor twice a year. I'm doing fine. I know there's a lot of individuals that aren't doing fine that I should see 4 times a year. So those are the things we're working on. If I Z codes or notice, like I had an admission the other day, a 911 admission for self-care issues, those are the kind of things that we have to wrap around and then find
Right.
how we can approach those individuals more frequently through the year to keep them in the home safely.
And Gina, I just bring that up because it may be a way, the first conversation dovetails with this conversation, so.
All right, everyone, it's lunchtime, but thank you again for all of your ideas. It was very insightful and encouraging. And thank you again to all of